Okay, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Shamsa. I am currently a second year fellow in pediatric cardiology. Today my lecture is about cardiopulmonary interactions. Actually, it's about the basics in cardiopulmonary interaction. It's a very important topic for all of us because thinking about how the heart and the lung interact is very important to decide on how to approach patients, especially patients with congenital heart disease. It also applies to patients with respiratory diseases, but it is very important when it comes to patients with congenital heart disease. If you are, for example, in the emergency department and a patient with a VSD is coming, is completely different than a patient who is coming with, for example, cyanotic spells in tetralogy of Fallot. And the same applies in the ICU. So managing a patient with a TGA post-arterial switch who has an LV systolic dysfunction is completely different than a patient with TOF post-repair and who has an RV diastolic dysfunction. So why do we need to think of the heart and the lung together? Because their main job, the heart and the lung, needs to work together in order to provide adequate tissue oxygenation. There are some basic equations that you need to be familiar with. Oxygen delivery is actually the product of cardiac output multiplied by the arterial oxygen content. So we need to optimize oxygen delivery in order to maintain adequate tissue oxygenation. Now, what is cardiac output? Cardiac output is the product of heart rate multiplied by the stroke volume. Now, we know that the heart rate is actually controlled by different things in the system. The basic thing is the sympathetic and the parasympathetic nervous system. So it's hormonal changes that control the heart rate. But the stroke volume is actually affected by afterload, preload, and contractility. We will go through it in more details in the next slides. Now, the next part of the oxygen delivery equation is the arterial oxygen content. Now, the arterial oxygen content is actually affected by hemoglobin and the arterial oxygen saturation. So that's why we always ask about the hemoglobin of the patient and also how much is the arterial oxygen saturation, because this will give us a clue on determining the arterial oxygen content. Now, 1.34 is a constant. The other part here is the amount of dissolved. So we call this one is the amount of oxygen which is bound to hemoglobin. So just think of all the oxygen in the blood is actually part of it is that oxygen which is bound to hemoglobin, and the other part is the dissolved oxygen. Now, the dissolved oxygen, you can see the constant factor here is very small, 0.003. So you end up with a small number in this part of the equation, and this is usually negligible. So we just focus on the hemoglobin and the saturation. Now, if we want to optimize oxygen delivery, we need to think of the cardiac output. We need to improve all the things that affect cardiac output and also improve the arterial oxygen content by optimizing your hemoglobin and avoiding hypoxia, of course. Okay, so this slide is showing us the different characteristics of the arterial and the venous circulation. We know that we have the systemic circulation and the pulmonary circulation in the body. The two circulations are connected by different vasculatures. We have the arterial vasculatures and the venous. The venous circulation is actually highly compliant, large capacitance, it has a large vascular reservoir, but on the opposite hand, it has a low resistance and low pressure. So in order for it to be highly compliant with large capacitance and large reservoir, it needs actually to have low resistance and low pressure for the blood to flow in. Also, the other vasculature is the arterial circulation, which is a low compliance, low capacitance, but it is highly resistance with a high pressure. Now, this is the most important slide that everyone needs to understand really well. This is a pressure volume loop of the left ventricle. Now, there is also a pressure volume loop of the right ventricle, which is beyond the scope of this lecture. On the x-axis here, we have the volume in ml, so the volume in the volume of blood in the left ventricle in ml, and on the y-axis here we have the pressure in millimeter of mercury. Let's start at the blue dot here. So we will start when the mitral valve opens. So which part of the cardiac cycle that is? This is diastole. So the mitral valve opens, filling in the left ventricle starts. You can see how much the volume in the left ventricle increases, but there is only slight increase in pressure. Then we come to a point here where the mitral valve closes. Then the next part of the cardiac cycle starts, where you have a very high change in pressure within the left ventricle, but there is no change in volume at all. This is called isovolumetric contraction. Both mitral valve and aortic valve are closed, so you have only increase in intracavitary pressure. Then the aortic valve opens, and then you start systole until you reach to this point where aortic valve closes. And then similarly, we have a phase where the pressure within the left ventricle drops significantly without a change in volume, and this we call it isovolumetric relaxation. Now, the amount of blood in the ventricle at the end of diastole is called end diastolic volume. Easy. Similarly, the amount of blood within the left ventricle at the end of systole is called end systolic volume. Now, the difference between the two is actually equal to your stroke volume. End diastolic volume minus end systolic volume is your stroke volume. If you divide this by end diastolic volume, you can calculate your ejection fraction. Now, there are two other curves that we need to explain. The black line here, which is the end diastolic pressure volume relationship, and this one represents the left ventricle compliance. It changes with changes in compliance. On the opposite side here, we have the end systolic pressure volume relationship, and this line actually represents the contractility of the left ventricle. So we will move on to the next slide. Preload and the effect of preload on the pressure volume. Now, let's say, so this is again the pressure volume relationship of the left ventricle, and how the loop changes with changes in preload, given that all other parameters, i.e. contractility, afterload, are normal. So preload, we said, is how much the left ventricle stretches before contraction. So if we have an increase in preload, which is the case here, so if we have an increase in your preload, which is the case here, that pink loop, so if you have an increase in preload, then see how much the end diastolic volume stretches. So you have a lot of volume in the left ventricle before it starts ejecting. So the difference between your end diastolic volume and end systolic volume is bigger than normal. So you have an increase in your stroke volume. On the opposite side, a reduction in preload is actually represented by this green loop. So if you reduce your preload, it means, just imagine that you don't have much volume in the left ventricle before it starts ejecting. So the difference between your end diastolic volume and end systolic volume is very much less than normal, and so you have a drop in your stroke volume and cardiac output. So what is the effect of preload? A reduction in preload will reduces your stroke volume and cardiac output. An increase in preload will increase your stroke volume and cardiac output. And this is important to think of it when it comes to managing your patients. Afterload. So definition of afterload is basically how much LV needs to work in order to eject all blood from it. So imagine like how much the left ventricle, how much pressure the left ventricle needs to overcome in order to eject blood out of it. So an increase in your afterload is represented by this pink loop. So an increase in afterload means the LV needs to work really hard in order to pump blood out of it. Then it will eventually close. The aortic valve will eventually closes before it empties all the blood. So the difference between your end diastolic and end systolic volumes have reduced compared to normal, and a reduction in afterload will lead to a drop in your stroke volume and your cardiac output. Similarly, a reduction in afterload is represented by this green loop, and it basically means the LV does not face much resistance. It doesn't need to work that hard in order to push the blood out of it. So it ends up pushing almost all the blood out of it. So the difference between your end diastolic volume and end systolic volume is huge. You have an increase in your stroke volume and an increase in cardiac output. So again, what is the effect of afterload on your cardiac output? A reduction in afterload will increase your stroke volume and hence your cardiac output. On the other hand, an increase in afterload will reduce your stroke volume and cardiac output. Now, contractility. Remember we said contractility is represented by this line here. So an increase in contractility will shift the whole curve to the left. So let's say, for example, the patient is getting inotropes. Inotropes will work on the contractility. You will end up having a bigger than normal difference between end diastolic and end systolic volumes, and an increase in your stroke volume and cardiac output. And the opposite is true. So for example, if the patient is having an LV dysfunction, the contractility is not as good, then there is a drop in your stroke volume and your cardiac output. Now the last one of the curves, we have the lusitropy. Lusitropy, basically it means compliance, and it's represented by this line here, your end diastolic pressure volume relationship. Now what happens if your LV becomes stiff? So you have a reduction in compliance of the left ventricle, then the whole curve shifts up and you have a smaller difference between your end diastolic and end systolic volumes, which means your stroke volume is less and your cardiac output is less. So with a stiff ventricle, you have a drop in your stroke volume and your cardiac output. Now, so we know that children differ amongst all of them in different things. Like we have different heart rate, normal heart rate, different ranges for different age groups. The respiratory rate is also the same. Also, when it comes to the newborn heart, it's actually stiffer, which means it is less compliant than the other children. So, what happens if you increase your end diastolic pressure within the ventricle of a newborn? Then, if you try to optimize the preload further, it will actually worsen their cardiac output. It will not help them. And that's why the stress to newborn actually augments their cardiac output by increasing the heart rate more than the stroke volume. They don't have much window on the stroke volume because of the compliance of their left ventricle. And that's why we have the highest normal heart rate ranges are for newborns. We accept higher than normal for them. Okay, so now we will move on to the next part of this lecture, which is about the respiration. So you need to think about the normal breath as being completely different than a positive pressure ventilation. In spontaneous breathing, we have two phases. Inspiration is usually negative and expiration is positive. And by negative and positive, we mean the effect of ventilation on or the breathing on the intrathoracic pressure. On the other hand, the mechanical ventilator is actually all positive throughout the respiratory cycle. Both inspiration and expiration are positive, and hence the name. Now, what's the effect of spontaneous breathing on the heart? So, two things happen during spontaneous breathing. One thing is there is a drop in the intrathoracic pressure. So, your intrathoracic pressure becomes more negative, and hence your right atrium pressure becomes also more negative. On the other side, the intra-abdominal pressure actually becomes more positive, and so you have a compression on your extrathoracic vessels, and by that we mean, for example, the IVC. So you have more pressure on the IVC to push blood back to the right atrium, because the right atrium preload is actually dependent on the amount of blood that comes into the right atrium from both the SVC and the IVC. And the flow, remember Ohm's law, the flow of blood is actually equals to the pressure gradient between the two areas divided by the resistance. In the blood, we don't have much changes in resistance. So the main important factor that determine the flow of blood in the heart or in the body is actually the pressure gradient. So we have more positive here and negative here, so blood flows into the heart. Now RV after load. So what determines RV? So we said when it comes to the LV is how much the LV needs to work in order to eject blood out of it. The same definition applies to the RV. So how much RV needs to work in order to push blood out of it? Now think about it. What does the RV face? So the RV is facing the pulmonary circulation. Now this graph is representing the lung volume on the x-axis and the pulmonary vascular resistance on the y-axis. Here we have residual volume, functional residual capacity, and total lung capacity. Now the best pulmonary vascular resistance to achieve for the RV to perfectly pump blood out of it is actually this area at the functional residual capacity. Why? Because if we are aiming the residual volume, then basically we're under ventilating the patient. So both under ventilation and here over ventilation are actually harmful for the patient or are harmful for the RV. Why? Because they increase the pulmonary vascular resistance. How does it do so? Under ventilation will causes the reactive hypoxic pulmonary vasoconstriction, because we don't have much oxygen there, we're under ventilating, so there is hypoxia and there is secondary vasoconstriction. this will increase your pulmonary vascular resistance. It means the RV needs to work really hard, so that is not good for the right ventricle. On the opposite side, overventilation, you will end up causing compression to the nearby structures and vessels, and hence your pulmonary vascular resistance also goes up, and the RV needs to work really hard to push blood out of it. So by adjusting ventilation, like adjusting the PEEP and the tidal volume, we should actually target this one, the functional residual capacity. So whatever the RV output is actually the LV preload, because whatever goes out from the right ventricle ideally should go back to the left ventricle in the absence of any shunts. And yeah, that's the Ohm's law, where we say basically the venous return, whether it's the systemic or the pulmonary, is actually equal to the pressure gradient between the two areas divided by the resistance. So the pulmonary venous return equals the mean pulmonary venous pressure minus the LA pressure, so that's the pressure gradient, divided by the pulmonary venous resistance. Interventricular interaction, this is very important concept to keep in mind. Now, if one patient has a dysfunctioned one ventricle, eventually it will cause, if we don't address it promptly, it will end up causing dysfunction of the other ventricle, because both ventricles share the same interventricular septum. Now, in the normal heart, because the LV pressure is actually higher than the RV, and this makes sense because the LV is facing the systemic circulation, right? And the RV, it's only pulmonary, so it's not the same pressure. Now the LV and the pressure is higher, so the interventricular septum is nice and round. Now if we have a dysfunctioned RV or an RV overload, with time it will cause RV dilation. And just imagine RV dilation pushing the interventricular septum to the left, and it becomes more of a D-shaped. Now the left ventricle doesn't have the same space as here. The other thing, this is going to increase the pressure within the left ventricle even further, which means the preload is going to be affected, and with time it will cause dysfunction of that left ventricle. Now blood pressure variation in inspiration and expiration. So during breathing, as we breathe in, we increase the venous return to the heart, and we increase the right ventricular preload. So there will be a bowing of the interventricular septum to the left side, and during that phase there is a slight reduction in LV compliance, which causes a decrease in LV filling and decrease in blood pressure. And this is the best explanation for the pulsus paradoxus. Remember, the definition of pulsus paradoxus is the change. So basically there is always around 10 to 15 millimeter of mercury systolic blood pressure drop during inspiration, and this is because of this interventricular communication. If it is exacerbated, then we need to think of other causes. So the LV afterload, it is all forces contribute to all myocardial wall stress. Now there are different factors that will affect the LV afterload. The elasticity of the vessels after the LV, so we're talking about the aortic valve, the aortic arch, the abdominal aorta, and all the vessels there. Then also ejection pressure, how much the LV is ejecting. If there is any ventricular outflow tract obstruction, if there is something causing an obstruction and the LV is not able to eject all the blood out of it. And also the ventricular wall stress. We will represent it by here, the next slide, which is nicely represented by Laplace law. So the wall stress, how much stress on the wall is actually affected by pressure within the cavity multiplied by the radius of the cavity and divided by 2 multiplied by the wall thickness. If we apply that to the left ventricle, then how much wall stress on the left ventricle we have is actually determined by the pressure within the left ventricle and how big the radius of the left ventricle is, and then the thickness of the left ventricular wall itself. Now, if there is a volume load or a volume overload within the ventricle, then this will increase your preload. This will increase the radius and the wall stress. On the other hand, if there is hypertrophy, so imagine patients who have left ventricular outflow tract obstruction, with time they will develop hypertrophy of the left ventricular wall. So an increase in the thickness of the left ventricle, because there is an opposite relationship, it will decrease the wall stress. So the same concept here about the transmural pressure. So we have the aorta here, and imagine this box here is the rib cage, the breathing. So if the patient is in quiet breathing, then, and basically the definition of a transmural pressure is the difference between the intracavitary and extracavitary pressure. So if the patient is in a quiet breathing, we assume his intrathoracic pressure space to be like 0, and the pressure within the left ventricle is 100. So 100 minus 0 is 100. What happens if the patient is having exaggerated negative intrathoracic pressure, meaning that the patient is having a stridor or is in significant respiratory distress? Then when it comes to calculating the difference, it will be 100, which is the pressure within the left ventricle, minus 25, which is the intrathoracic pressure, and that equals to 125. So basically the LV needs to work even harder to push blood out of it. Now if the patient is on positive pressure ventilation, then we're giving a positive 20, for example, in the intrathoracic cavity. So 100 minus 20 equals 80. So look how the LV needs to work less when it comes to positive pressure ventilation. So the LV really likes positive pressure. It's much easier for the left ventricle to push blood out if the patient is on positive pressure ventilation. And this is basically, imagine the patient is having a vasodilator therapy, like for example they're on furosemide infusion or they're on melanoron, so the whole thing is actually less. So just remember, the LV works less hard when the patient is on positive pressure ventilation. So that's why initiation of positive pressure ventilation acts as an LV assist device. Patients with LV dysfunction, they really like positive pressure ventilation. So we shouldn't be hesitant to start positive pressure ventilation in any patient who has LV dysfunction. Now, LV afterload is actually exacerbated by excessive negative intrathoracic pressure, as we demonstrated in the previous slide. So if the patient is crying, having a stridor or laryngospasm, and in respiratory distress, then this is more work for the LV to work. So this one is important to keep in mind, because patients with LV dysfunction who have been on positive pressure ventilation, ideally we should avoid extubating them to room air, for example. We should transit them to another non-invasive positive pressure ventilation. to help them and to help their dysfunctioned LV. So clinical implications, I will try to make it nice and simple. So this one we already mentioned. Patient who have LV systolic dysfunction, it means they have a problem with contractility, and hence their cardiac output is actually less. Now, cardiogenic pulmonary edema reduces lung compliance and lead to exaggerated negative intrathoracic pressure, and so the LV afterload actually goes up. And these are the explanations for the drop in cardiac output in patients who have reduced LV function. Now, we already mentioned that positive pressure ventilation helps them to reduce their afterload, and there is actually one study that demonstrated that prolonged use of non-invasive positive pressure ventilation for at least 4 hours per day for 6 months led to ventricular remodeling and hence improved function. LV diastolic dysfunction, they have a problem with their compliance, so they will have inadequate ventricular filling, and so in those patients the positive pressure ventilation induces a drop in the venous return, and so it's poorly tolerated and may induce LVOT obstruction, especially in HOCM. So see how the difference between systolic and diastolic dysfunction affects the management completely different. When it comes to the RV, so RV diastolic dysfunction, think of it in patients who have TOF, like post-repair. Then those patients actually, they don't like positive pressure ventilation. As you remember that graph, the lung volumes, we said we should aim for the functional residual capacity. And we should aim for early extubation in those patients because it will help to improve their cardiac output. Cavopulmonary shunts, so those are patients who are post-Glenn and post-Fontan. They usually come extubated from the OT because they are dependent on passive flow, and we don't want any positive pressure ventilation in those patients. So take-home messages, positive pressure ventilation impairs the RA preload as compared to spontaneous breathing, and we should target functional residual capacity to low pulmonary vascular resistance to improve the RV afterload. LV preload depends on the right-sided condition, and LV afterload is actually improved by positive pressure ventilation. I hope this was useful, and if you have any questions, then you can approach me anytime and anywhere. Thank you very much.